Welcome to the marathon season of NEETABLE MDS Pathshala podcast. I am your host, Dr. Thingra, and you are a NEETABLE. Tune in for a new episode every day till the NEET MDS 2022 exam. In this episode, let's do a rapid browse through various important topics in general medicine. So let's get started. First of all, we'll look at infections. So I'll tell you some viruses and their related infections. The first one is herpes simplex virus type 1. It can cause primary stomatitis, keratoconjunctivitis, encephalitis, herpes labialis, cold sores it is also called, and herpetic whitlow, that is finger infection. Then herpes simplex virus 2, that is type 2, can lead to genital infections. Moving on to cytomegalovirus, it can cause congenital infections, pneumonitis, retinitis, and diseases in immunocompromised patients. Coming to a very important virus, which is Epstein-Barr virus, it can cause infectious mononucleosis, Burkitt's lymphoma, nasopharyngeal carcinoma, and oral hairy leukoplakia, which mostly occurs in AIDS patients. Then coming to varicella zoster virus, it can cause chickenpox and shingles, which is also called as herpes zoster. So remember, herpes zoster is not caused by herpes virus, it is caused by a variation of a herpes virus, which is varicella zoster virus. Coming to human herpes virus 8, that is HHV8, it leads to Kaposi sarcoma. Again, it is common in AIDS patients. Now I'll list down some of the common complications of various infections. So a common complication with measles is otitis media. For rubella, it is polyarthritis. A common complication of mumps in children is aseptic meningitis. In adolescents, it is orchitis or ophoritis. Then streptococcal pharyngitis has a complication of rheumatic fever. Typhoid, the common complication is paralytic ileus. And for tetanus, the common complication is airway obstruction. Coming to different diseases and their manifesting rashes. So characteristic rashes appear with relating to various diseases. First one, chickenpox. The rash appears on the second day of infection and it appears first on the trunk, maximum on the trunk. Lesion at all stages of development can be seen. Then moving to scarlet fever, there is a diffuse erythematous rash and blanching on pressure occurs. The face is not affected and the rash disappears in about 7 to 10 days. For rubella, there is a maculopapular rash which starts on face and moves towards the trunk. Then for measles, there is a maculopapular rash which usually begins in the hairline and behind the ears and spread to the neck, chest and extremities. These lesions increase in number rapidly and coalesce to form blotchy, discolored, irregular lesions. For erythema infectiosum, there is a characteristic slap cheek rash. For smallpox, the rash involves maximum on face and leaves pitted scars. For typhoid, at the end of first week, a rash appears on the upper abdomen as sparse, slightly raised, rose-red spots which fade on pressure. In eczema or atopic dermatitis, there is a monk's cowl rash over face and neck. In pellagra, there is a sunburn rash and necklace rash. In bromide poisoning, there will be acne-form rash. And in kwashiorkor, there is crazy pavement epithelium rash and moist areas are mostly affected. Coming to some characteristic spots and their related diseases. Koplik spots, it occurs in measles on buccal mucosa. For Scheimer spots occur in rubella in soft palate. Roth spots are seen in infective endocarditis in the eye. Rose spots are seen in abdomen in typhoid patients. Herberden's nodes are seen in osteoarthritis. And Bitot spots are seen in vitamin A deficiency in the eye. Next, we'll see some infections and their related incubation periods. So, short incubation periods are seen with anthrax, diphtheria, scarlet fever, typhoid and cholera. Intermediate periods are seen with measles, mumps, rubella and chickenpox. And long incubation periods are seen with hepatitis A, B, tuberculosis and leprosy. So coming to short incubation periods, for anthrax it is 2 to 5 days, for diphtheria it is 2 to 5 days, scarlet fever it is 1 to 3 days, for typhoid it is 5 days and for cholera it is 2 to 3 hours. Moving to intermediate, for measles the incubation period is 7 to 14 days, on an average 10 days. For mumps, the incubation period is 2 to 3 weeks, on an average 18 days. For rubella, the incubation period is again 2 to 3 weeks, on an average 18 days. And for chickenpox, the incubation period is 14 to 21 days. Then long incubation periods. Hepatitis A has an incubation period of 2 to 6 weeks, on an average 4 weeks. Hepatitis B has 6 weeks to 6 months of incubation period with an average of 12 weeks. And tuberculosis has an incubation period ranging from few months to few years. And leprosy has an incubation period of 2 to 5 years. Now next very important infection is syphilis, and it's important to know the clinical features. Many MCQs are asked on this area. So syphilis can be categorized as congenital syphilis, primary syphilis, secondary syphilis and late or tertiary syphilis. So let's see what are the clinical features under each of these. Congenital syphilis has a characteristic Hutchinson's triad which displays hypoplastic incisors and molars, interstitial keratitis and eighth nerve deafness. Apart from the Hutchinson's triad, you can see saddle nose, Sabry tibia, ragades, that is radiating scars around the mouth, nose and anus, bossing of frontal and parietal bones, hypoplastic maxilla and salt and pepper scars on the retina. In primary syphilis, you can find a painless chancre and painless palpable rubbery inguinal lymph nodes. In secondary syphilis, now this stage is highly infectious. It starts 6 to 8 weeks after the development of the chancre. There will be fever and malaise, maculopapular rash on the trunk and limbs, condyloma lata, that is papules coalescing to plaques, mucus patches in the genitalia, mouth, pharynx, and you'll find snail track ulcers in the mouth. In late or tertiary syphilis, you can find characteristic granulomatous lesion called gamma, cardiovascular syphilis. There will be aortitis, aortic aneurysm, which mostly is in ascending aorta, aortic incompetence, neurosyphilis, tabes dorsalis, meningovascular disease, and general paralysis. So these were the clinical features of the various syphilis forms. Next, now in the chapter Central Nervous System, I'll talk about cerebrum and their lobes and which function they relate to. So frontal lobe, it relates to personality, behavior, emotional control and language. Then parietal, the dominant part, it relates to language and calculation. Parietal lobe, non-dominant part, relates to spatial orientation and construction skills. Then temporal lobe, dominant part, has a function of auditory perception, smell, balance and verbal memory. Temporal lobe, non-dominant part, has functions of auditory perception, smell, balance and non-verbal memory. And occipital lobe has a function of visual processing. Now I'll tell you the differences between upper motor neuron lesions and lower motor neuron lesions. The power is decreased in upper motor neuron lesions, but it is much decreased in lower motor neuron lesions. Tone is hypertonia in upper motor neuron and hypotonia in lower motor neuron, that is, there will be flaccidity in lower motor neuron lesions. Then wasting or atrophy is minimal in upper and marked in lower motor neuron lesions. Under reflexes, the superficial reflexes are lost in both the lesions. Deep reflexes are exaggerated or brisk in upper lesions and absent or reduced in lower motor neuron lesions. Clonus is present in upper and absent in lower motor neuron lesions. Fasciculations are absent in upper and present in lower motor neuron lesions. And reaction of degeneration in muscle is absent in upper and present in lower motor neuron lesions. Now let's see different types of seizures and the choice of anti-epileptic drugs used. First type is tonic-clonic seizure. The first line drugs used will be phenytoin, carbamazepine and valproate. The second line drugs for tonic-clonic seizures are lamotrigine and oxycarbazepine. The next seizure is myoclonic seizure. The first line drug is valproate and second line drug is lamotrigine. In absence seizure, the first line drug is valproate again and second line drugs are ethosuximide and lamotrigine. For partial seizures, the first line drug is carbamazepine and second line drugs are valproate, lamotrigine and oxycarbazine. Now let's browse through the chapter GIT, liver and kidney. One important concept is metabolic acidosis and metabolic alkalosis. So let's see what are their features. In metabolic acidosis, there will be increase in bicarbonate, increase in H+ ions, and decrease in partial CO2. And the causes of metabolic acidosis are diarrhea, hypovolemic shock, starvation, alcoholism, diabetic ketoacidosis, lactic acidosis, and chronic renal failure. Now in metabolic alkalosis, there will be again increase in bicarbonate but reduced H+ ions and increased partial CO2. The causes of metabolic alkalosis are vomiting, diuretics, chronic respiratory failure, aldosteronism, and Cushing syndrome. Metabolic acidosis can be managed by giving IV bicarbonate infusions, and metabolic alkalosis can be managed by IV 0.9% isotonic saline, that is NaCl solution, and KCl infusion. Coming to next, which is also commonly asked, the clinical features of hepatic cirrhosis, that is also called as chronic liver failure. The clinical features are jaundice, hepatomegaly but gradually liver size decreases due to hepatocyte destruction, ascites, spider telangiectasia, Palmer arrhythmia, loss of libido and gynecomastia, bruises, epistaxis, portal hypertension features, that is splenomegaly, collateral vessel, variceal bleeding, and fetor hepaticus, and there will be clubbing and pigmentation. Now next topic, what is a polyp? A polyp is a small excrescence that grows into the lumen of the colon and rectum. So a variety of polyps can be seen, which are described here. The first one is tubular or villous polyp, which is seen in familial polyposis syndrome or Gardner's syndrome. The malignant potential is 7% for tubular and 33% for villous polyps. Coming to hematoma polyps, these are juvenile polyps and the polyps in Peutz-Jeghers syndrome. They have a low or uncommon malignant potential. Then inflammatory polyps, or also called as pseudopolyps, they can be seen in inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease, and they also have a very low malignant potential. Now let's discuss the common causes of urinary stones. So urinary stones are calcium conjugates with oxalate. Oxalate excretion in kidney predisposes to stone formation. Apart from that, other predisposing factors can be either environmental or dietary, acquired causes, or congenital and inherited causes. Among environmental and dietary causes, it includes low urine volumes, high ambient temperatures, low fluid intake, and in diet, if there is high protein, high sodium and low calcium, then high excretions of oxalate, sodium and urate, and low citrate excretion. Acquired causes can be hypocalcemia due to any cause, ileal disease or resection, which increases oxalate absorption and urinary excretion, and renal tubular acidosis type 1. And some congenital and inherited causes can be familial hypercalciuria, medullary sponge kidney, cystinuria, renal tubular acidosis type 1, and primary hyperoxaluria. Let me also list down the common causes of acute pancreatitis. The causes include gallstones, alcohol, hypertriglyceridemia, trauma, sphincter of Oddi dysfunction, and some drugs such as azathioprine, sulfonamides, estrogens, tetracycline, valproic acid, and anti-HIV medications. Now, chronic alcohol abuse accounts for 1/3 of the cases of acute pancreatitis, although only 5% of chronic alcohols develop this complication. About 5% of patients with gallstones develop acute pancreatitis, and the risk for this disease in patients with gallstones is 25 times higher than in the general population. Now, another important topic from oral perspective is dysphagia, which is difficulty in opening of mouth. There can be various causes of dysphagia, broadly classified into esophageal dysphagia and oropharyngeal dysphagia. For esophageal dysphagia, the causes include due to stricture, that is carcinoma esophagus, carcinoma of stomach, and peptic ulcer, or due to esophagitis such as in cases of peptic or candidiasis, and dysmotility such as in cases of achalasia and non-specific motility disorder. Oropharyngeal dysphagia on the other hand is mostly due to neurological diseases such as bulbar palsy, pseudobulbar palsy or multiple sclerosis, myasthenia gravis, polymyositis, diphtheria, Guillain-Barré syndrome, and Parkinson's disease. Next, we'll be dealing with some concepts from hematology and endocrinology. First of all, hemophilia's different types and their affected factors. So, classical hemophilia or hemophilia A is due to deficiency of factor 8. Hemophilia B or Christmas disease is due to deficiency of factor 9. Hemophilia C is due to deficiency of factor 11. Then von Willebrand disease, or also called as vascular hemophilia, is due to deficiency of von Willebrand factor, and parahemophilia is due to deficiency of factor 5. Now coming to platelets, what is the normal platelet count? It is 1.4 to 4 lakhs per millimeter cube. Abnormal increase in number of platelets is called as thrombocythemia or thrombocytosis, and abnormal reduction in the number of blood platelets is called as thrombocytopenic purpura. Now what is prothrombin time or PT? The extrinsic pathway is assessed by the prothrombin time. Normal prothrombin time by Quink's one-stage method is 10 to 14 seconds. It is normal in hemophiliac patients. It is prolonged in the following diseases. First is deficiency of factors 1, 2, 5, 7 and thrombin, vitamin K deficiency, liver diseases, patients on anticoagulants such as dicumoral, heparin, warfarin and salicyclate therapy, and in disseminated intravascular coagulation, that is DIC. Next, what is partial thromboplastin time or PTT? The intrinsic pathway of coagulation is assessed by PTT. The normal value is 26 to 37 seconds. It is prolonged in deficiency of factors 1, 2, 5, 8, 9, 10 and 11, and in hemophilia and in liver disease. Next, bleeding time. According to Duke's method, the bleeding time normal is 1 to 5 minutes, and Ivy's method says that bleeding time is 2 to 7 minutes. Bleeding time will be prolonged in thrombocytopenic purpura and von Willebrand's disease. Coming to clotting time. As per capillary tube method, the clotting time is 1 to 7 minutes. As per Cruz and Moss's method, the clotting time is 2.5 to 5 minutes. And as per Lee and White method, clotting time is 4 to 9 minutes. Again, clotting time will be prolonged in hemophilia. Now there is something called as clotting retraction time. Platelet adhesiveness and platelet aggregation can be determined by clotting retraction time. It usually sets within 6 hours and is completed by 24 hours. It is impaired in thrombocytopenic purpura. Now if the platelet count falls below 40,000 per millimeter cube, then hemorrhagic manifestation occurs, and so this value is also called as critical count. Coming to leukemias, leukemia is mainly of 4 types: acute myeloblastic leukemia AML, acute lymphoblastic leukemia ALL, chronic myeloid leukemia CML, and chronic lymphocytic leukemia, that is CLL. Now some important features of AML or acute myeloid leukemia are malignant transformation of undifferentiated precursors of myeloid series. WBC counts will be up to 1 lakh per millimeter cube. There will be more than 30% myeloblasts present in blood and bone marrow. It is common in all ages, and gingival hyperplasia is most common in this. Next, important features of acute lymphoblastic leukemia or ALL. This is the malignant transformation of undifferentiated precursors of lymphoid series. Here the WBC counts are up to 1 lakh per millimeter cube with more than 30% of lymphoblasts. It is common in young adults and children, and gingival hyperplasia is less common in this condition. Next, important features of CLL or chronic lymphocytic leukemia. This is malignant transformation of well-differentiated cells of lymphoid series. It is common in elder age group. Here WBC count is up to 5 lakhs per millimeter cube with less than 10% of lymphoblasts. and gingival hyperplasia is again less common in CLL. Coming to important features of chronic myeloid leukemia or CML, this is the malignant transformation of well-differentiated cells of myeloid series. It is common in middle age. The most consistent chromosomal abnormality is the Philadelphia chromosome, involving the reciprocal translocations of part of long arm of chromosome 22 to the long arm of chromosome 9. Remember, chromosome 22 to chromosome 9. An increase in basophils up to 10% is the characteristic feature of CML, and WBC count is up to 5 lakhs per millimeter cube with less than 10% of myeloblasts seen, and gingival hyperplasia is very common. Now I'll list down some diseases and their peculiar abnormalities which are seen in peripheral blood film. In thalassemia, you can see microcytosis, teardrops and target cells. In megaloblastic anemia, you can find megaloblasts and hypersegmented neutrophils. In malaria, you can find Scuffner's dots. In hereditary spherocytosis, you will find microspherocytes. In infectious mononucleosis, you find atypical lymphocytes. In aleukemic leukemia, you can see circulating leukoerythroblasts. In post-splenectomy patients, there will be Howell-Jolly bodies, target cells, spur cells and spherocytes. And in sepsis cases, you can find neutrophilia and Dohel bodies. Now coming to diabetes mellitus, what are the characteristic features of diabetes mellitus? So there will be polyuria, polyphagia and polydipsia. Then there will be glycosuria, which occurs when blood glucose rises above the renal threshold level, that is above 180 mg per dl. There will be ketoacidosis, Kussmaul's breathing, circulatory shock and coma, bone resorption, loosening of teeth, multiple fleeting periodontal abscesses, and acetone breath. Now diabetes mellitus is of two types, type 1 and type 2. Type 1 is insulin dependent diabetes mellitus and type 2 is non-insulin dependent diabetes mellitus. Type 1, that is insulin dependent, is due to deficiency of insulin. It occurs due to destruction of beta cells during autoimmune diseases, destruction of beta cells by viral infections, or in congenital disorder of beta cells. It is not associated with obesity and it is not hereditary. It is commonly associated with acidosis or ketosis or coma, and it usually occurs in young age groups. Also remember a term, childhood diabetes is called juvenile diabetes. Then type 2 or non-insulin dependent diabetes mellitus, it usually occurs after the age of 40 years. It is called as maturity onset diabetes. The structure function of beta cells is normal, but diabetes develops due to reduced number of insulin receptors. It is associated with obesity and is hereditary, and it is very rarely associated with ketosis. Now coming to two very important endocrine disorders, hyperthyroidism and hypothyroidism. So what are the differences in their features? Hyperthyroidism, there will be palpitations, tachycardia, dyspnea, atrial fibrillation and hypertension. In hypothyroidism, there will be bradycardia, hypertension and congestive cardiac failure. Then in hyperthyroidism, there will be weight loss despite normal appetite, goiter and diffuse bruit. In hypothyroidism, there will be weight gain, goiter and hoarseness and tiredness. In hyperthyroidism, there will be heat tolerance, whereas there will be cold tolerance in hypothyroidism. Then hyperthyroidism is related to amenorrhea or oligomenorrhea, and hypothyroidism is related to menorrhagia. Then you can find nervousness, irritability, emotional lability and tremors in hyperthyroidism, whereas there will be carpal tunnel syndrome, depressions and aches and pains in hypothyroidism. In hyperthyroidism, there will be pigmentation, pretibial myxedema and increased sweating. In hypothyroidism, there will be dry, flaky skin, alopecia and myxedema. Then finally, in hyperthyroidism, there will be lid lag, lid retraction, exophthalmos, diplopia and papilloedema. In hypothyroidism, you can find macrocytosis and iron deficiency anemia. Some interesting facts. Acetone breath is characteristic of diabetes mellitus. Musty breath is characteristic of hepatic coma. Uremic breath is characteristic of renal disease. And alcoholic breath is found in alcoholics. Now, relation of calcium and phosphorus, that is serum calcium and serum phosphorus, to some important diseases. In rickets or vitamin D deficiency, there will be increased serum calcium but decrease in serum phosphorus. In chronic renal failure, there will be decrease in calcium but increase in serum phosphorus. In hyperparathyroidism, increase in calcium, decrease in phosphorus. In hypoparathyroidism, decrease in calcium but increase in phosphorus. And in osteoporosis, both calcium and phosphorus are normal. Now, important parameters in anemia. In iron deficiency anemia, ferritin decreases, iron decreases, total iron binding capacity increases, transferrin saturation decreases, and soluble transferrin receptor increases. In anemia of chronic disease, ferritin will increase or it can be normal, iron will decrease, total iron binding capacity decreases, transferrin saturation is decreased or normal, and soluble transferrin receptor is decreased or normal. Moving forward, the next system, that is respiratory system. Now there are two types of respiratory diseases. They can be obstructive or restrictive. Some obstructive diseases are asthma, COPD, that is chronic bronchitis and emphysema, bronchiectasis, cystic fibrosis and bronchiolitis. And restrictive diseases include interstitial lung diseases, which can be sarcoidosis and fibrosing alveolitis, neuromuscular diseases, and chest wall diseases like kyphoscoliosis and ankylosing spondylitis. Now, the total lung capacity in obstructive diseases is normal or it can be increased. In restrictive diseases, it is decreased. The residual volume in obstructive diseases is increased. In restrictive, it is decreased. Vital capacity decreases in obstructive and also decreases in restrictive. Then FEV1, that is forced expiratory volume in 1 second, or forced vital capacity, it decreases in obstructive and is increased in restrictive. Diffusion capacity is normal in obstructive and decreases in restrictive, and lung compliance is unaffected in obstructive and decreased in restrictive. Now some common respiratory diseases. What is bronchiectasis? It is a suppurative lung disease characterized by abnormal dilatation of bronchi and accumulation of pus beyond a lesion obstructing the major bronchus. Then COPD, it is chronic slowly progressive disorder characterized by airflow obstruction which does not change markedly over several months. Chronic bronchitis and emphysema, they constitute COPD. So what is emphysema? It is a pathological process of permanent destructive enlargement of the spaces distal to the terminal bronchioles. Pink puffers is predominantly emphysema. And chronic bronchitis, it is any patient who coughed up sputum on most days at least 3 consecutive months for more than 2 successive years. Blue bloaters is seen in bronchitis. Next, various types of sputum and their associated pathology. Purulent sputum is found in bronchiectasis and lung abscess. Mucopurulent is found in active bronchopulmonary infections. Pink frothy sputum is seen in pulmonary edema. Black sputum is characteristic of anthracosis and aspergillosis. Rusty sputum is seen in pneumonia. Red sputum is seen in bronchial carcinoma. And foul smell of sputum is found in lung abscess and bronchiectasis. Moving on to some characteristic breath sounds. Vesicular breath sound is characterized by active inspiration due to passage of air into the bronchi and alveoli, followed without a pause by passive short expiration. The sound is rustling due to passage of air through alveoli. The normal breath sounds are vesicular. So in normal conditions, the breath sounds will be vesicular. Next is bronchial breath sound. It is characterized by active inspiration due to the passage of air into the bronchi. The alveolar phase is absent and expiration is also active, occupying the same duration of time as inspiration. There is no rustling quality of sound. It is heard in patients with cavity, consolidation, partial collapse, pneumothorax, and above the level of pleural effusion. Next is bronchovesicular sound. Here there is active inspiration due to passage of air into bronchi and alveoli, giving vesicular type of inspiratory sound. During expiration, there is increased resistance in the airway due to spasm causing expiration to be active and prolonged. It is seen in bronchial asthma and COPD. Moving to rales sound, it is crackling sounds that originate in the smaller bronchi or alveoli due to explosive opening of the airways. These are inspiratory rales seen in chronic bronchitis, bronchiectasis, cavity, lung abscess and fibrosis. Then rhonchi or wheeze is seen in COPD, asthma, that is expiratory wheeze, and bronchitis. And finally, stridor. Stridor type of breath sound is a loud inspiratory sound heard over the airways due to obstruction to the respiratory tract. Obstruction to the larynx causes laryngeal stridor, and obstruction to trachea causes tracheal stridor. Finally, let's look at chest deformities and their characteristics. Pectus carinatum, that is pigeon chest, it is seen in severe asthma during childhood. It is also seen in rickets. Then pectus excavatum or funnel chest. Here the body of the sternum, usually the lower end, is curved backwards, and this deformity restricts chest expansion and reduces vital capacity. Barrel-shaped chest, it is seen in COPD. The normal ratio of anterior-posterior to lateral diameter of chest is 5:7. In emphysema, the AP diameter of the chest is increased related to the lateral diameter, which leads to barrel-shaped chest. And finally, kyphoscoliosis. It is an abnormality in the alignment of dorsal spine caused by polio, trauma, or a congenital abnormality. It restricts and distorts the chest wall. So this brings us to the end of the rapid revision or browse through series of general medicine. Join the Telegram group for updates on MDS preparation and your doses of motivation. I'll see you in the next episode. Till then, happy learning, NEETABLEs.